in that premolar area here. And this one I call 4-unit bridge or implants. There's decay around here. We're going to lose this one, possibly lose this one. There's decay around here. So this 3-unit bridge is in jeopardy. This patient's got a lot of history of root canals. At least they've been successful. That's great. She will have other issues in the future, but this is her current issue now. And we got to see that the decay is too far here. Possibly that we can't really do much with it because you can get right underneath the entire crown. It's probably non-restorable. This one is still possibly restorable, but then if you're going to do a bridge system, you're now into canine to first molar. So that could work for a while, but is that what you want to do? Well, let's look at our treatment assessment here. It doesn't look so good. We have a very poor bone density profile here. Look at how poor this is. We'll look at it in a second with the CT, but it's red. We have facial bone is orange. We have yellow constriction. We have then greens on detached gingiva, etc., etc. So the rest are okay there. But the poor porosity here on this case is what's going to kill you on the healing here. Now there is an oral surgeon I know, he places graft material into these cases. He doesn't say he has a lot of experience with success with it, but that is a possibility because once you go in, it's just like air. It's going to be very, very, very soft. The implant's not going to, it'll seem like it has a grip, but it's only really gripping around that apical crestal part of the bone. Or I should say the crestal ridge of the bone as the implant threads through. But you can easily push that through and lose sight of that implant actually. It's almost like going into the sinus and losing it in the sinus. So here we go. We've got now a discussion here. So let's look closer at the CT. And we want to look at this particular site here. If this tooth comes out, what are we going to do? Is that going to be an implant site? It's got this weird S-shaped curvy root. So ideally the implant's going to be here. It's going to be very difficult to put the implant here because half the implant is in socket side, half is in native bone or supposedly native bone. There's not a lot of strong native bone here. Even though it's very soft, you still have the cortical nature of the socket site around there. It's very difficult to maintain it in the position you actually want it with the drill sequence you're going to do. Now, let's look at that more in a straight down the nerve position here. You have very thin facial plate bone way up here at the top. You could see the bone here on the lingual side, and it would go across here. So very thin here. So if you're going to do anything here, you definitely have to graft that and let that heal up. You might want to let it heal a little bit longer than the 3.5-4 months that I normally recommend, but you get the idea. You definitely want to heal that up. Definitely, you're not going to be able to tell how hard that bone actually is because the graft, everything will be still fairly soft. So for somebody that has been doing a lot of implants, they'll understand that this is a very bad situation. And your likelihood of success falls into the miracle category. And that's a little bit dreamy to expect that that's going to occur and be successful. So my recommendation actually is to keep things simple. And possibly if you lose this and you can save this, do the 4-unit bridge. I wouldn't go into a lot of time and expense. So I explain to the patient that they should be spending money on scaling, root planing. They got some periodontal. They got a lot of calculus buildup here. They're going to need a lot of maintenance on the other teeth here. And that this should work out fine as a 4-unit bridge. Just, even your bite out. Maybe not bite as hard. I don't see her as a hard clencher biter. But I'm not crazy about implants in this site. And I would recommend her not to do that for the reasons I just explained. And that's a problem because patients are going to just go find another doctor more likely, and that doctor is going to find that they're going to have a problem with that implant site as well. So 2 weeks, they could get things back to normal, get back to quality of life. But when you take this out, you graft it, maybe you put the implant in there, maybe you try all the compression, maybe you add graft material, maybe you try some sort of growth factors, I don't know. I doubt you're going to be all that successful long term with this case, and the patient's going to come back within 5 years, even if you're successful in the first 6 months. So is that really worth it? In my opinion, no. She's got good roots. She needs a crown here. So, yeah, that's just a matter of opinion. If you do feel like you've got to be a little heroic on the implants, or you want to try it out, I guess this is one of them to do it, and you will learn and see and find out if I am wrong. So, anyway, that was an interesting case study to kind of look at what seemingly would be a simple looking case. If you're only using a Panorex X-ray, you're going to fall into a trap thinking that this is actually really good bone. The nerve is very nicely placed south of where the crest is. Everything looks pretty ideal, so you might get duped into putting an implant into this site. So that's about it. That's this case study, quick and dirty, and hopefully we will see you at another case study. Take a look at all of those other videos I do, as well as you can watch out for some of our live broadcasts. You can like us on Facebook and subscribe to us on YouTube. Thanks. I appreciate it.